And welcome to this Special Joint Committee on Medical Assistance in Dying. This is our 19th meeting. I welcome the members of the committee. I also welcome our witnesses and the members of the public who are joining us by web. I am Marc Garneau, and I am the House of Commons' Joint Chair of this committee. I am joined by the Honourable Yona Martin, the Senate's Joint Chair. Today, we are continuing our examination of the statutory review of the provisions of the Criminal Code relating to medical assistance in dying and their application.
Members and witnesses to keep their microphones muted unless recognized by name by one of the joint chairs. A reminder that all comments should be addressed through the joint chairs. When speaking, please speak slowly and clearly. Interpretation in this video conference will work like an in-person committee meeting, and you have the choice at the bottom of your screen. You probably can see the interpretation button, which gives you the choice of floor, English, or French. With that, I would like to welcome our witnesses for Panel 1 who are here to discuss the state of palliative care in Canada. As individuals, nous avons le Dr.
We have Dr. Geneviève Dechaine, who is a family doctor.
James Downer, Professor and Head, Division of Palliative Care at the University of Ottawa. And we have as well Mr. Spencer Hawkswell from Therapsil, President and Chief Executive Officer. Thank you for joining us this morning. We'll begin with opening remarks. You will have each of you 5 minutes to speak, and we'll start with Dr. Dechaine. À vous la parole, Dr. Dechaine.
The floor is yours, Dr. Dechaine.
Merci de me permettre.
Thank you. Thank you for giving me a chance to address the Special Joint Committee on Medical Assistance in Dying. Home care is an important issue, and I'd like to talk to you about access to home care for palliative care and MAID. I'm an expert in this matter as of 35 years now in Quebec. I am including long-term home cares when I speak of home care. In Quebec, clinicians have unfortunately failed so far to convince decision makers of how important it is to offer complete palliative care in home care settings and long-term care. I'm speaking of multi-expert teams, at least a doctor and a specialist being intensively offered 24 hours a day. These are efficient, 65% fewer hospitalizations and 64% of peaceful dying in home care for those who receive these care. These are good teams, and they exist in English Canada and in Europe. Unfortunately, Quebec clinicians are still struggling to ensure that there are sufficient palliative care services for patients who are in home care and of sufficient length, 8 months, not 7 years, as set in 2019 by Quebec authorities. International data proves that home care, palliative care are superior care. Nurses dedicated to the practices are provided with extra training and time to handle these difficult cases and to support caregivers and family who are very involved in home care settings. It's not a basic practice. It's not a basic hospital practice. We also know that not all doctors are trained or experienced in addressing existential suffering at the end of life. These patients are complex. Their conditions are not stable. It has been shown in a number of scientific publications that palliative care doctors address suffering better, more quickly, and at lesser cost to a healthcare system. Despite this, in Quebec, there's still a serious lack of such doctors available for home care service. It's really a medical desert, affecting from 80 to 85% of all Quebecers at the ends of their lives. Palliative care specialists hope that these services would finally be offered across the board, along with MAID, thanks to the application of the 2015 legislation in Quebec regarding end-of-life care. Because to respect this legislation, everything must be done to address the suffering of end-of-life patients before applying MAID. And this includes physical and mental and psychological strain and suffering. Unfortunately, more emphasis is put on MAID than on palliative care. This is absurd because both of them are essential and they are complementary. There are means of measuring the access to care, and we have in Quebec the lowest level of death at home in the Western world, 12% compared to 30% elsewhere in Canada and in Europe. This is something that we see on a regular basis in our overworked emergency care units in our hospitals. Most people want to receive care and die at home. In Quebec, our family doctors put in a number of hours at the hospitals. When we visit home care settings, patients often speak of MAID. They don't even know that they have a prognostic which gives them only 12 months or less to live, especially when they are cancer patients, and they tell us that they're desperate, that they're suffering continuously, and that they're stuck in hospital care, too many people in the room, and so on and so forth. When home care is offered, patients are really cared for, and fewer of them choose MAID. In fact, very few of them. Moreover, the end-of-life care legislation in Quebec provides for palliative care and MAID for all Quebecers in any care setting, including in home care and long-term care, but that's not what's going on in Quebec. Lack of access is ongoing, and most of the healthcare system gives priority to hospital care. In Quebec, even in 2022, your postal code decides where you're going to die. We must do better than this. We need to stop focusing on hospital care, accept that in the Western world now, people live long, and that we must provide expert medical care at end of life. Thank you. Thank you, Dr. Deschênes.
To Dr. James Downer. Dr. Downer, you will have 5 minutes.
Thank you, Mr. Chair. I really appreciate the opportunity again to speak before you and want to thank Dr. Deschênes for her comments, largely focused on home care. I will try to keep my comments perhaps focused on the hospital, just so that I don't repeat what she was saying, but I agree with what she was saying. I think some of the, I've provided some material.
Monsieur le Président.
Mr. Chair.
Un petit peu parce que en salle.
We need to adjust the sound because the sound is much too high in the room for me to be able to hear the translation without really turning it up so high. It's going to hurt my ears.
Very good. Sorry, Dr. Downer, we're just making a little adjustment to sound. It's nothing to do with you.
No problem.
Please, please carry on.
I have small children, so I'm used to telling people to use their inside voice. So the main points I wanted to communicate today, I think, is that although I think there have been, it's important to acknowledge that there have been important improvements in funding and support for palliative care in many, many parts of the country. This is a start. It needs to continue. I think a lot of the more acute crises that we are experiencing.
Je m'excuse, je vais pas faire mon
Hold on again.
Mon mal commode aujourd'hui et je m'excuse auprès du.
I'm sorry to be interrupting everyone, but I'm not hearing the French translation.
Translation momentarily. Hold on, Dr. Downer.
Il n'y a pas de problème. Je peux continuer en français.
I can continue in French if you wish.
Okay, we have it back on. Carry on in English or French, whichever you prefer.
This is going to be a fun morning. I would like to just, I think it's very important to point out that a lot of the crises that we are experiencing right now in palliative care and palliative care provision are related to a generalized lack of person power across the healthcare system, and especially in home care. We need more nurses, we need more personal support workers, and particularly, but most importantly, we need to add to our labor pool in those areas without stealing from other areas. So simply throwing money at palliative care, stealing staff from the hospitals or from long-term care, we're just going to move one crisis into another place. And we've done that a few times during the pandemic. So just be careful. But I think importantly to recognize that a lot of the crisis, even before the pandemic, the lack of funding or the inadequate amount of palliative care beds and palliative care home resources had a very important upstream effect on the healthcare system as a whole. Probably 1 in 5 or 1 in 6 patients admitted to a hospital was simply waiting to go to another facility, another bed that didn't exist. And as a result, that was heavy contribution to our overwhelmed acute care facilities. The even more sad part of that is that all of the places they were waiting to go, the beds are cheaper than the beds they were occupying in acute care. And we just published a report in the CD Howe report a year ago suggesting that even if you just took the patients who were in the final 90 days of their life, and that's almost half of the patients who are what so-called alternate level of care or ALC patients in a hospital, almost half of them are in the final 90 days of their life. If you move those people to the bed they were waiting for, you would save hundreds of millions of dollars a year while improving care for those patients and alleviating the healthcare crisis. The acute care crisis is actually really predominantly an end-of-life care crisis, and that's what we really need to focus on right now. I think I also want to highlight the importance of improving support and funding for palliative care research in this country. We have definitely had an increase in the previous couple of years. A large amount of funding was given to the Pan-Canadian Palliative Care Research Collaborative. A large amount of funding was given in Alberta to the Palliative Care Institute. These are great starts. Please keep going, because we really do need to improve our ability to treat many types of suffering, and in particular, existential suffering, which is very common. It is the number one factor in people requesting medical assistance in dying, and there is currently no proven therapy to address that type of suffering. It is very important, and but we have promising therapies. We just need some support to help do that research and start to advance our field. Improving palliative care is a moral imperative for all Canadians, independent of medical assistance in dying. Only the tiniest minority of Canadians actually choose medical assistance in dying at the end of life. We need to improve, and 98% of those people receive or have access to palliative care. There are many people who don't have access to palliative care or don't get good palliative care. They're not getting MAID either. So this really isn't about MAID. This is about improving end-of-life care for all Canadians. And maybe I'll just say, I think there's probably an opportunity to answer questions, so I'll just bring my opening comments to a close with that. Thank you.
Thank you, Dr. Downer. We'll now go to Mr. Hawkswell from Therapsil. Sir, you have 5 minutes. We're not hearing you, although I see you're unmuted. Could you just hold on a second? We won't start your time yet. So, Mr. Hawkswell, do you have an unmute button on your cord? Do you want to try?
Test.
Yeah, that worked. That's working now. Good. All right. So please go ahead.
My first time. Thank you. So I'm a patient rights advocate and the CEO at Therapsil, a nonprofit dedicated to supporting patients in accessing psilocybin, a substance commonly found in what's otherwise known as magic mushrooms that has an amazing ability to help people through the therapeutic process, usually has been used in studies to help people with end-of-life distress. I am here today to advocate for a number of our constituents and patients who have the right to die in Canada with medical assistance in dying, but currently are being denied their right to try psilocybin. Specifically, I'll refer to a patient, Janice Hughes, a 65-year-old woman in Manitoba with stage 4 breast cancer and an advocate with a 2-year prognosis who, in her own words, states that it is not only patronizing, but infringement upon my charter rights to have a Canadian government deny me access to psilocybin, a substance that has helped me with my palliative care treatment and end-of-life distress, while allowing me at the same time only one alternative, medical assistance in dying. Now, to relate what this has to do with MAID, it is about improving palliative care and adjunct or prior therapies. Now, the last time psilocybin was brought up in this meeting, it was shot down as a pseudoscience for its lack of research and not having much to do with medical assistance in dying. However, firstly, in relation to the research, I might remind everyone that there's actually quite a bit of research behind psilocybin, specific research coming out of Johns Hopkins and NYU, that does far surpass much of the research that was done for medical cannabis and perhaps medical assistance in dying, as these were both legalized on the basis of human rights. And that is what we were talking about here today, a human rights issue in need of compassion. Secondly, to answer how MAID is connected to the psilocybin issue, the people that I represent, such as misuse, are directly affected by this committee. Psilocybin access is currently available through the Special Access Program to those who have failed every other treatment, leaving MAID as one of their only alternatives if psilocybin is not allowed. This represents a woeful incongruency in our healthcare system, and I believe that should this committee be aware of this incongruency, that there may be a situation where we are allowing people to die before they're able to try substances such as psilocybin that might help them alleviate end-of-life distress and with their palliative care before MAID. What I'm asking is, where is the compassion? Why is there not a more patient-centered approach where constituents and stakeholders of the actions of this committee are being told that they're being denied prior adjunct treatments to MAID? I'm personally a big supporter of medical assistance in dying, and I've agreed with everything I've heard so far. We must move it forward quickly, but we must also see it in the context of palliative care in Canada, especially where patients are being denied access to other therapies. Bill C-14 and Bill C-7 required establishing this committee in the House of Senate and Commons to conduct a comprehensive review of the criminal code, MAID provisions in their application, and issues relating to mental illness and the state of palliative care in Canada. I believe that this is what we are talking about, is the state of palliative care in Canada. I am here to defend the Canadians with mental illness and those struggling to receive adequate palliative care. As a healthcare system that prides itself on being patient-centered and giving people the right to die, after the Carter Proclamation, that if I don't have the right to die, then whose body is this? But at the same time, we'll limit these same Canadians by expanding MAID while ignoring issues related to adjunct or prior treatments, such as psilocybin access. I believe that this is unconscionable, and that given the very constituents affected by this committee review will be subject to broader options relating to medical death, while the request to seek treatment such as psilocybin to better their quality of life is being ignored. I don't believe that the members of this committee should let such a thing happen, and I'm asking for your compassion and support for people like Janice. I believe that Canadians who have the right to die should similarly have the right to try psilocybin and perhaps other controlled substances prior to MAID. I believe, however, that we should start with psilocybin access given the robust research, but that we should expect this to increase to other treatments and substances that may hold other grounding. I'm urging this committee to add in its report that regulations to medical psilocybin access for those seeking MAID should be given a priority, and that a number of Canadians seeking this, that should be a possible prior treatment. I do not intend in any way to slow down any of the other work that is being done on MAID and any other issues, but rather to encourage the expansion of other alternative treatments at the same time. Again, I'm referring to psilocybin. So I'm here to defend people like Ms. Janice Hughes and hundreds of other patients who have reached out to our organization, feeling disheartened that we might make MAID available in as little as 3 days, while someone like Ms. Hughes has waited 7 months for access to psilocybin and been forced to break the law in order to access it. I do not believe that this reflects well upon the state of palliative care in Canada, and believe that similarly to the comments made by Dr. Danner, that this is simply a reflection of other therapies, adjunct and prior therapies that need to be made available while our MAID committee is expanding possible options for medical assistance in dying. Please consider. Thank you.
Thank you, Mr. Hawkswell. We'll now go to questions, and I'll hand it over to my co-chair, Senator Martin.
Thank you, Mr. Co-Chair. Thank you to our witnesses for your testimony today. So we'll go into our first round of questions, and we will begin with Madame Vien for 5 minutes.
Merci beaucoup.
Thank you very much, and hello to all. Thank you to our witnesses for being available to us here this morning. Hello, Dr. Duchesne. Hello. Welcome. I read an article that you had published, if I'm not mistaken, in 2021. Very interesting. You brought up something in that article that really seemed of interest to me, and we'll get back to it, the NOVA project in Verdun. But before we go there, you have shed doubt on our common understanding of how accessible services are. You've spoken of unequal access, and you said, and this is quite striking, that in Quebec, our postal codes are what decide where we'll die. Yes, in Quebec, right. So what's the issue? Is it access to home care or access to palliative care at home? Thank you for this excellent question. We have what are called local community services institutions called CLSCs in Quebec. These are fabulous. They offer very good services in home care settings. All the professionals are represented, nurses, doctors, ergotherapists, physiotherapists. Everyone's there except, well, actually, doctors are not included for political reasons and probably union-based labor reasons as well. Doctors are not included in this exemplary care model, the CLSCs in Quebec. Palliative care. In the last 12 months of life, I'm not speaking of the actual death process over the last 7 days. I'm speaking of palliative care, which is what's offered in the last years of life, just don't work without access to a doctor. Let's say that you have a cardiac issue, you have water in the lungs. Medication must be changed on an ongoing basis, intravenous or oral, day by day, hour by hour. This requires access to a doctor, either actual in-person visits or at least access by phone. Our nurses are excellent, but I'm sorry, I will run out of time, Dr. Deschênes. Yes, as I was saying, doctors aren't there. That's the explanation. So you mentioned political grounds for this, union or labor reasons as well. You've mentioned that palliative care can reduce costs. So where's the bottleneck? I thought that it might have been a matter of skill sets or training of our doctors in Quebec, but you say it's a political and a labor issue? Indeed. I appreciated Dr. Downer's opening statement. He explained that palliative care in all settings, not only in home care, is an extra care, if you say. It's a specialization. Not any doctor can suddenly decide that they're a palliative care expert just overnight, especially when it comes to the settings, long-term care or home care. But it's worse than that. We're not even able to reach the doctors who do have this training if you're operating the CLSCs. So if I understand correctly, this seems to be a political problem. People have not yet been convinced that they should adopt palliative care in Quebec. Now, on the other hand, you have said something about a project you wanted to highlight that you think is very good, and is it something that could be imitated outside of Quebec? Yes. You probably know of NOVA in English Canada, given that they are associated with the Victoria Order of Nurses, these super community nurses who are there to support the healthcare service nurses working in home care. So this is something you've got across English-speaking Canada. So in Quebec, we call it NOVA. These people offer considerable assistance as well as their high levels of expertise to nurses already working in the CLSCs that I was mentioning earlier. And many of them are specialized in palliative care. They're able to support and to mentor other nurses across Quebec. How could this be capitalized on? Dr. Deschênes, I understand that in the Verdun CLSC, that's in an urban setting, yes? Yes. Nova Home Care is already helping 17 CLSCs in the Greater Montreal region. There are also other nursing groups like the Société des Infirmières de Montréal in Western Montreal. East Montreal, rather. Unfortunately, these groups are not recognized or financially supported on an equal basis, given the work they're carrying out. And by the way, they cost less to the healthcare system than the nurses in the public health system. So it's a good option that we should work more closely with.
Pierre, for 5 minutes.
Thank you, Madame Co-Chair. Bonjour à tous nos témoins.
Hello to all our witnesses, and thank you, Dr. Deschênes, for your comments. Just a couple of questions to understand you clearly. So you're saying that a family doctor is not the same as the CLSCs, and you're saying there are no doctors available at CLSCs? Yes, they're two different entities in Quebec. Thank you. You said that these problems require expert care. So what exactly is expert home care that's palliative care? Thank you. Wonderful question. In family medicine, there are some specialized practices. You don't have to go all the way through your doctor training again, but you get a special internship, 2 or 3 months, and you're supervised by other specialists for another 3 months. After those 6 months, you are authorized to carry out a specialized practice. My patient is not at 2 in the morning. If you're a regular family doctor, turning up at 2 in the morning in a state of extreme suffering. Palliative care is more or less being hospitalized at home. In the hospital, you have to be available to your patients at 2 in the morning. Same thing for home care. And I must underscore that you're dealing with patients who are unstable, conditions are unstable, complex conditions. They need to have access to actual medical care, actual doctors 24 hours a day. Otherwise, they'll wind up back in the hospital. This is the most considerable crisis in our healthcare system across the land.
Province. Nos chiffres de décès à domicile.
Our death at home figures show it. Only 12% of people are able to die at home. This is extraordinarily low compared to the 30% in the rest of English-speaking Canada, or in English-speaking Canada. But what would we need to do to turn this around? Let's say I'm at end of life, I'm at home. Does a nurse come to, live in my home or 24 hours a day, or how does this work? In my presentation, I said that caregivers, so family members and so on, are actively involved in the care. The activities are delegated to them, such as administration of opiates, monitoring of vital signs. Not all patients can stay at home until the very end of their life, but from 64 to 65% of them are actually kept at home until they passed. And nurses are already there. They're highly skilled. They're extraordinarily competent. They have developed expertise in palliative care. But who can they call at Friday evening, 9 p.m., if their home care patient is struggling to breathe? That's the only piece we're missing in Quebec.
Pardon, je voudrais juste ajouter.
I would like to add something about what's going on outside Quebec. There are problems everywhere in Canada. But there are many ways to fill in the gaps. In Ontario, we have several teams, various models of how to work up the teams able to provide extra care to home care patients. You have pointed out what's needed to provide this care at home, and you've mentioned that often we haven't enough doctors who do visit homes. It's important to be able to create the teams of specialists. It can be a nurse practitioner, by the way. Sometimes we have various levels of nurses who together provide the services, compound their skills, and so on. It can be a family doctor who's available on call to provide evaluations and advice and prescriptions. For more complex cases, we sometimes use teams of palliative care specialists able to provide home care. Usually that's what we see in large urban centers. So as I say, there are a number of models that are used. As Dr. Deschênes has pointed out, it's important to create models that do support the professionals. Sometimes it's difficult for doctors to earn a full salary if they spend their time in home visits. But in Ontario, we have special salary systems to compensate for that.
We'll now go to Monsieur Thériault for 5 minutes.
Merci.
Thank you. I will address Dr. Deschênes first. It's very refreshing hearing what you have to say here to us today, inasmuch as the focus of the Quebec legislation on end-of-life care, what was really relevant there was the attempt to stop lining up medical assistance and dying and palliative care as being one and the same thing. So what you have to say is really helping us sort this out. So we have a system that leads people to be dying in hospitals. The end of their lives is spent in hospital settings. But you're saying that if everyone had access to palliative care, no one would be calling for MAID, as indeed that's not quite what you're saying. Just confirm that for me. You're quite right. In Quebec, we have 3.4% of deaths are via MAID. And I think we will rise to the 4 or 5% which is the Belgian and Swiss percentage, if we respond to patient needs and requests. But in brief, often patients will call for MAID if there's no doctor around to otherwise address their suffering. So that doesn't seem very acceptable to me. Yes, MAID, and correct me if I'm wrong on this in your opinion, but MAID must be taken as one choice within a continuum of care that's offered to our citizens. Often people say that, if there isn't palliative care, of course people will turn to MAID, and that's why people are turning to MAID. That said, palliative care overall, and if you have a proper system that includes all these approaches, and I'll ask you to define what that would look like for you, can be there to help someone move towards the end of life up to the point when they are really ready to let go and be ready to say, today is when I would like to leave. I'm fully comfortable with this. I am at peace, and now I choose MAID. So then that's a successful blending of the two approaches. And would you agree with that? Okay, letting go, the way you've described it, given that 97% of our patients are not dying with MAID, and I can't say that they have refused to let go. No, it's because someone told me at one point that the vision of people making their own choices, seemed to be based on a way of really managing death up to the last moment, that people were obsessed with the idea of controlling their own deaths, and therefore they requested MAID in order to control their deaths. But if rather they're actually waking up, thanks to good palliative care, one morning saying, look, now today I'm ready to let go, then that's not a matter of excessive control. What do you think? Well, most wish to remain alive through to the very end, to their natural death. Most of them do, because they have people there to relieve their suffering, to accompany them to the very end. They're not abandoned by the healthcare system. And not in Verdun only do we find these ideal services. Many areas of Quebec are well served. Often people ask for MAID, I believe, due to existential, psychological suffering, more than physical suffering. We do have medical methods to relieve suffering, even to put people to sleep forever. But MAID is not necessarily the solution if it's used alone. It must be used with palliative care. Okay, I'm not sure I got that. You're saying that if we have good palliative care, there is no need, or people don't wish to call for MAID, to receive MAID? No, quite the contrary. If you offer good palliative care, about 96% of patients will not call for MAID. I didn't say 100%. And this is based on, well, patients who speak to us who say that they have been able to have a quality of life up to the end of their lives, who are not suffering, who are calm about their decision. Often these are patients who decided ahead that they wanted to use MAID, that haven't a physical pain, but are suffering existentially, and at the end really want to control the very end of their life, to decide when they leave, and that's something we should respect.
Of Mr. McGregor, you have 5 minutes.
Thank you, Madam Co-Chair, and thank you to all of our witnesses for appearing today. Mr. Hawkswell, I'd like to direct my questions to you, if I may. It's good to see you join our committee today. And I really did appreciate how your comments were focused on a patient-centered approach. We, as a committee, have previously had Dr. Valerie Masuda appear before us, who's one of my constituents. She's a palliative care physician, and she has seen firsthand with her patients how psilocybin in a controlled environment has definitely relieved their anxiety, the existential dread that they feel when they are approaching the end of their life, and has allowed for them to focus on that part of their life with friends and family present and with a much more sound mind. You mentioned the research from Johns Hopkins, and just reading from their website, I'll quote the website, quote, "Research to date demonstrates safety of psilocybin in regulated spaces facilitated by medical team over a series of guided sessions and as a part of cognitive behavioral therapy. Psilocybin helps in reducing anxiety in some cancer patients and facilitating even smoking cessation for some." So can you just add a little bit more to just what that research is pointing towards? And later on, would you be able to submit some of that research to this committee so that we can consider it as we're approaching our final report?
I can absolutely submit some research and opinion pieces from the patients and doctors if you would like. I believe they're very helpful and outline more patient-centered cases where both patients and healthcare professionals as well as families have been helped by this. I will just add a bit more on the use of psilocybin and what we've seen in near about 100 treatments that our organization has helped facilitate with doctors such as Dr. Val Masuda. Psilocybin, the compound, it alone does not alleviate much of the end-of-life distress. It's commonly referred to that, but it is the combination of anxiety, depression, or hopelessness that a patient faces when they're told that they're going to die. Again, this does not affect every cancer patient, but some of the literature reviews we've done, which we'll also try to include, show that about 2,800 Canadians every year fall into this category of treatment-resistant depression or anxiety due to an end-of-life diagnosis. What the psilocybin does is, coupled with psychotherapy, which is what you're referring to, and the Hopkins was referring to when it said that it's conducted with clinicians in a safe space. That space can be the patient's home. That's where much of the treatments have been done. That the psilocybin aids in the psychotherapeutic process. It allows people to put their guards down. In many cases, it allows for the therapist to actually do the work that they need to do. And for many people, the psychotherapeutic process is hindered by lies that people tell themselves, by fears. And in many cases, the patients coming out of these experiences are reporting that they are no longer afraid of death. They feel a oneness with the universe. It is essentially years of psychotherapy packed into a single session with the help of a medicine.
Thank you. I just want to, I have limited time left. Now, Psychedelics Canada, they are asking for three key things. They want more research from the federal government into this, to the Canadian Institutes for Health Research. They want clear, effective, and evidence-based regulations, and they want pharmacist compounding of psychedelic substances under Health Canada's Special Access Program. Can you add a little bit more to that and put it in the context of the barriers you have faced under current regulations, i.e., what kind of recommendations would you like to see this committee make in its final report so that we are making sure that end-of-life care truly is a patient-centered approach?
There's just under 1 minute.
I'll be very quick
Thank
then.
you.
I will comment on the Special Access Program and regulations. Firstly, the Special Access Program, which was amended in January of this year to facilitate psilocybin use, is a complete and total failure. 18 patients have been granted access. Val Masuda, the doctor, one of your constituents, can attest to the fact that the SAP program is a failure, and Health Canada is now telling us and many of the doctors and patients that they are to not use the SAP and to use clinical trials, which is wrong here. We need regulations. We need medical regulations. Our organization has written those medical regulations and submitted them to the ministers of health. And that is those medical regulations fall right in line with the medical cannabis regulations, which again are based on human rights. That's what we're looking for, the human right to try psilocybin, especially for those for whom it works.
Thank you very much. And now we'll go to our round of questions from the senators. I'll turn this over to my co-chair.
Thank you, Senator Martin. We'll begin with Senator Mégy. Sénatrice, vous avez 3 minutes.
Senator, you have 3 minutes. Thank you, Mr. Chair. My first question is for Dr. Deschênes. Hello, Dr. Deschênes. Hello, Honorable Marie-Françoise Mégy. In the notes, we receive reports and so on, and even legislative texts. We see a good deal about palliative care and about MAID. People who aren't working in this area sometimes confuse the two. I would like you to tell us exactly what palliative care is, the last 12 months of life, and end-of-life care. Thank you. It's a very good question. Look, Quebec's Medical College has helped us provide a definition that works for all. They have I participated in a document that they have published called the 18 Days of Life. But that's not palliative care, or rather 7 last days of life. That's really end-of-life care. Palliative care is what you can provide to someone who has an incurable disease, who is suffering from it, and who is facing an end of life, a life-limiting illness. Let's say that doctors are dealing with an illness. Sometimes they know when someone will die, sometimes they don't. Someone can die from one day to the next. Let's say they have a cardiac illness, then they will also tend to have trouble breathing. You need help to manage that through the end of their life. And of course, palliative care is not something that interferes with or stands in for standard medical care. You can receive morphine to help with difficulty breathing, and this can be something you need over months' time, not really years, because in the West we don't die of pneumonia, at least not very often. We die of chronic illnesses. There was something that we tried to clarify with the prior witness. What is good palliative care? What's a good definition of good palliative care? The World Health Organization, as well as the Canadian Association of Palliative Care, have specified what that consists of. All medical specialists must be included. There is the basic combination, the duality of a doctor and a nurse, available in all settings 24 hours a day. Over and beyond that, you need the other care represented, nutrition specialists, social works, and the very important home care specialists who are able to help the person eat, move around, remain clean, interprofessional teams, basically. Thank you, Senator. That's the 3 minutes, I'm afraid, and we will now turn to Senator Kutcher. 3 minutes, sir.
Thanks to all the witnesses. Observation, gosh, 3 minutes goes fast. Our family has had personal experience with excellent home-based palliative care, and I agree that improving home-based palliative care is essential to providing more end-of-life choices. And we've known for decades that health human resources across Canada are inadequate in all kinds of health care, including in palliative care, so this is not unique to palliative care. But we also have heard, so Dr. Downer, we've also heard arguments that MAID funding is stealing resources that were originally directed for palliative care, or that funding for MAID is causing deficits in funding for palliative care that is being, instead of palliative care, is being specifically directed to MAID. Can you have your thoughts on these concerns?
Yeah, I've heard these claims too, but I don't think there's really any basis for them. I think in most cases, in many parts of the country, palliative care funding is increasing and increasing quite substantially. My own division in Ottawa has roughly doubled in size, including a large increase in salaried positions over the past few years. I think that has largely been the case in much of Ontario. I know that is not the case across the country. I'm not claiming that it is, but definitely there's been a substantial increase, I think, in funding for staff, funding for beds, which unfortunately we're just generally missing staff that we can't always fill. So that's super important to state. In terms of resources and our resources being stolen, I think it's also important to remember that if somebody has, if somebody is at end of life and is suffering and they're getting resources, I would say that I find it hard to understand why people would say that that's an inappropriate use of palliative resources. I think that's I really regret if any member of the palliative care community would say that that's stealing resources. The resources belong to the patients. They're patient resources, not my resources and not anyone else's resources. They're for them. And if they're nearing the end of life and suffering and the resources go to them, good. And the fact that they've chosen MAID shouldn't make them ineligible for resources.
And Dr. Duchesne, thank you so much for being here. Your sister is a great senator. Could you give us your comments on what Dr. Downer told us? What was your perspective on that?
I would not add a word more. Thank you, Dr. Downer. I agree completely with him.
Is that why you get all the questions? It's because your sister.
Well, she's supervising me. I have to be, short answers, so I'm trying to do so.
So I think I have 48 seconds left.
You have 18 seconds left.
Oh, dear. We have seen chaos in nursing homes during the pandemic. Do you think that we should recommend a pan-Canadian approach to improving care for our elderly? Everyone who's elderly, not just an end of life, but all elderly people in this country?
Je vais répondre en français parce que c'est une question.
I'll answer in French because it's a delicate matter. I think that health is a provincial jurisdiction, so these are decisions to be made by the provinces. I think that we, as Canadians, so speaking for us as a whole, should receive a minimum level of care, not only palliative care, but also geriatric care in long-term settings, coast to coast. Thank you very much. And now the floor is Senator Delphonse. 3 minutes, sir. Thank you, Mr. Chair. My questions are for Dr. Downer and Dr. Duchesne. Dr. Duchesne, you've mentioned 88% of people who had asked for MAID also received palliative care. You've also said that there are insufficient resources to provide palliative care to those people who perhaps didn't have it. So those who do access palliative care at home have less of a tendency to choose MAID. That's what you've told us, yes? Thank you for the question. I would say that we know that those who've received palliative care in home care settings are the same people who receive MAID. So if we study these groups, yes, these is the same population, so it's difficult to say whether they're receiving MAID has to do with or not with their receiving or not receiving palliative care at home. That's what's clear to us. Allow me to add something. Okay, but is there a difference between those in home care and those who are in hospital care because there is insufficient space in long-term care settings? Yes. Let's tell the truth. We don't really have data on that differentiation. But if you live in a large urban community, it's going to be, or in a rural community, it's really the same level of MAID that we've found used in both those areas of Canada. The important thing to know is that the reason why people are requesting MAID is usually due to existential suffering, to things for which we don't really have effective treatments, even in palliative care. So that even if people who request MAID receive the best palliative care available in Canada, they will probably still be asking for MAID, and that's why. I think that Dr. Deschênes wished to add something. The data you're referring to are Canadian data. What's very surprising in Quebec, despite the report that has been produced for years after we adopted the end-of-life care, that we have no data about palliative care being offered in home care settings. In Quebec, we couldn't even answer your question, which is very unfortunate. Thank you. And we now turn to Senator Martin for 3 minutes.
Thank you very much, and thank you to all of our witnesses. Dr. Deschênes, you really helped me and us understand the importance of quality home care, and especially quality home care and palliative care. So I'm just wanting to give you the rest of my time to sort of go into any of the key recommendations that you would have for our committee to ensure that people aren't being pushed to access MAID due to a lack of access of home care, palliative care, chronic pain services, and mental health services. So would you go into the key recommendations that you have for our committee?
Merci pour cette très belle question. Alors,
Thank you for your excellent question. I would hope that across Canada, not only in Quebec, palliative care of the best type be offered to all patients. As Dr. Downer has said, the patient could be at home, but be able to access specialists by phone for end-of-life care. Not only cancer patients, although cancer patients do represent 50% of these cases. So access full care based on their needs. So those who need more, those who need less, everyone should have access to what they need. And MAID, as I say, is something that improves proper palliative care. We have about 3% of our end-of-life deaths are due to MAID in Quebec. The percentage is rising quickly. I think that's a trend that will continue. I'm not judging that, but I do feel we need to meet patients' needs.
Downer's hand. Did you want to add something to that?
Sorry, I didn't know there was a comment that I wanted to respond to something Mr. Hawkswell said previously, and I'm sorry. I don't know if this is a good time for that.
So, Dr. Deschênes, is this? It seems like what's happening in Quebec in terms of home care and palliative care. Is this the fact that there's a lack of access and enough specialists? Like, is this a problem across Canada then? Are you aware of?
No, I'm not aware of. Sorry, I'm just speaking for Quebec province. I have not studied the other provinces. Nothing is perfect nowhere in Canada, but obviously the figures we have of the number of patients dying at home shows that Quebec is far worse as for access to palliative care. Our guess, but the government is not working on this data, unfortunately, is that 85%, maybe even 90% of all patients in their last year of life, unable to go to a hospital or a clinic to have their medical care, have no medical care at home. That's a lot.
Yeah, I would think the same issues are prevalent in other provinces and territories as well. But thank you very much.
Thank you.
Thank you, Senator. Malheureusement, le temps file.
Unfortunately, we've run through our time and reached the end of our first panel time. So I would like to thank our witnesses. Thank you, Dr. Deschênes and Dr. Downer.
Thank you for coming and providing testimony this morning, answering our questions. We very much appreciate it. With that, committee, we will suspend for a few minutes to move to our next panel. Thank you.
Excuse me, Chair. Could I ask a question? It's me.
Senator Kutcher?
Thank you. Dr. Downer was wanting to make a comment on an earlier
It's a very
question.
quick one.
I promise. If he can't do it, he could put it in writing to us, either way.
Yeah, I think probably it's best to put it in writing. We would appreciate it, Dr. Downer. We have to stay within the protocols of this meeting. Thank you. But
Absolutely.
please send it to the committee. Thank you.
It's about regulations. Thank you so much.
Okay, thank you. With that, we'll suspend.
Welcome once again. We will reconvene to hear our second panel.
Let's make a few comments for the benefit of our new witnesses. These are housekeeping rules. Please, before speaking, please wait until one of the co-chairs recognizes you by name. A reminder that all comments should be addressed through the joint chairs. When speaking, please speak slowly and clearly. This is for the benefit of our interpreters. Interpretation in this video conference will work like an in-person committee meeting. You have the choice at the bottom of your screen, if you're remote, of either floor English or French. That's on the little globe that has the interpretation. It's the interpretation button. And when you're not speaking, please keep your microphone on mute. And with that, I would like to welcome our witnesses for the second panel. Again, we're looking at palliative care. We have online with us Dr. Jose Pereira, Professor and Director of the Division of Palliative Care of the Department of Family Medicine at McMaster University. We have in the room with us Mr. Mike Kekowicz, Director of the Champlain Regional MAID Network, Center for Healthcare Ethics. And we're hoping, I see him. No, I'm not sure I see him yet, but we're hoping to have Dr. Louis Roy, qui est un médecin du Collège des médecins.
Who is a Collège des médecins du Québec physician, and we're waiting for him.
Joining us, and we will start with opening remarks from our three witnesses. We will start with Dr. Pereira. Each witness will have 5 minutes for opening comments before we go to questions. So, Dr. Pereira, you have the microphone for 5 minutes.
Thank you, Honourable Chairs, and thank you to the committee for the invitation to discuss palliative care in Canada. As you've heard, I'm Professor and Director of Palliative Care at McMaster University, and I'm also co-founder and scientific officer of Pallium Canada. I have dedicated most of my career to improving palliative care in Canada and abroad, and I've worked in different clinical, education, research, and leadership roles in several Canadian jurisdictions. And I'm pleased to appear before you to share my experiences and insights on palliative care. I'd like to use a brief time to highlight 3 areas related to palliative care in our country: access and availability, education, and funding. While we have seen noteworthy improvements across all 3 areas in the last 2 decades, many gaps still exist. We cannot say today that all Canadians have access to palliative care. In fact, many still do not. The good news is that there are examples of excellence in all these areas across the country, and there are solutions as well. Let me start with access to palliative care and palliative care services. On average, only about 30 to 50% of Canadians who need palliative care have access to it or receive it, whether it is delivered by palliative care specialists or by other healthcare professionals. On average, only about 15% to 25% of patients have access to specialist palliative care teams to address more complex needs. In many rural and remote areas of the country, there is no access to specialist palliative care, and many of the healthcare professionals serving those populations, just like their urban colleagues, lack core palliative care skills. A growing body of research shows that palliative care should be initiated early in the illness, not just in the last days or weeks of life. It improves quality of life and reduces anxiety and depression, caregiver distress, hospitalizations, and importantly also healthcare costs. Despite this, we consistently see palliative care activated very late in the illness, and I see that often in my clinical practice, and studies confirm this. Whether you'll get the palliative care you need depends largely on where you live, what you're dying from, and how close you are to death. Some areas, excellent access, others, almost nothing. You're also less likely to receive palliative care if you're poor, Indigenous, homeless, or incarcerated. The availability of and access to key palliative care services is still a patchwork across our country. For example, experts propose at least 10 palliative care inpatient beds for every 100,000 inhabitants. This includes palliative care units and hospice beds. Many jurisdictions across the country do not attain these standards. Some do, many don't. Many hospitals across the country do not have sufficient palliative care physicians and nurses, and many communities do not have adequately staffed palliative care specialist teams to support family physicians and home care nurses to provide home and community-based palliative care. The COVID-19 pandemic has had a major impact on the home care workforce. We struggle to discharge patients from hospital because of lack of home care, palliative care supports. Canadians need assistance in living and supports. This is a crisis. The pandemic has also highlighted chronic deficiencies in the integration of palliative care in long-term care homes. But again, there are centers of excellence. In the area of education, we have too few palliative care specialists in the country and too few training positions for new palliative care specialists. However, all the palliative care needs of a population cannot be met by palliative care specialists alone. We must train up professionals in primary care and across many specialty areas to provide a palliative care approach. This has been highlighted in the government's 2018 framework on palliative care. Many learners across the health professions are still graduating without core skills. In Canada, for example, less than 1 in 3 medical students complete palliative care clinical rotations during their training. In residency training, only 60% of family medicine trainees completed clinical rotations, and the numbers are lower in other specialty areas. Many practicing professionals in primary care and across different specialty areas do not have core palliative care skills. Interestingly, in a study of 10 OECD countries, only 42% of primary care practices in Canada felt prepared to provide palliative care. The number was 80% in the UK. To help address this gap, Pallium Canada, a non-profit organization that I co-founded 22 years ago, has trained over 40,000 healthcare professionals across the country on the palliative care approach. We also now train carers and help build compassionate community programs, but this still represents less than 6% of the workforce. Funding is needed to spread these initiatives. The public also needs to be educated on what palliative care actually is and what it can offer. And this finally brings me to funding. Sustained and adequate funding by federal, provincial, and territorial governments is needed to ensure access to palliative care services and education. Too often, it's piecemeal. We applaud some provincial governments, such as the government of Alberta, who have recently invested in palliative care training en masse, and the Nova Scotia government, who are training PSWs on a large scale. Federal funding is required to provide the necessary infrastructure and resources to implement the key priorities outlined in the framework of palliative care in Canada. Thank you very much, Honourable Chairs.
Thank you, Dr. Pereira. Nous irons maintenant au Dr. Louis Roy.
I now recognize Dr. Louis Roy, who has joined us for his opening statement. You have 5 minutes, sir. Hello, and thank you for hearing me. The interpreter points out that I don't think that the witness has chosen his headphone. I'm
de traduction et de qualité de son. Alors.
Hello.
OK. Alors,
we have a sound quality issue. I'm sorry, I interrupt you. Have you chosen your headphones as being the source to transmit your voice with? Because right now we're being heard through your computer. And do you know how to do this? Let me check. Yes, this should work.
Alors peut-être ce que je vais faire.
So perhaps what I will do is have a technician contact you. Is this working now? I'm afraid it isn't. A technician will reach out to you, and we will move on to Mr. Kakowicz, and we'll get back to you again, Dr. Roy. Is that acceptable? Thank you.
Mr. Kakowicz, if you are ready, the floor is yours for 5 minutes.
Thank you very much, Mr. Chair and members of this committee. Good morning, and good morning to my fellow panelists as well. I'm the director of the Champlain Regional MAID Network here in Ottawa, and we provide care to patients throughout the Champlain region, going from roughly Pembroke all the way to Hawkesbury. I'm also the director of the Champlain Centre for Healthcare Ethics, both of which are hosted at the Ottawa Hospital here in town. I'd like to make a few comments on what we're presently experiencing with respect to MAID, and then talk a little bit about palliative care, given that's the subject of today's discussion. So first, I just want to comment on the most recent data from Health Canada, which shows that MAID continues to grow quite substantially from year to year, representing now 3.3% of deaths in Canada. We're seeing the same trend in this region, in this province, and it's very clear that more and more Canadians are inquiring about and accessing this service. And I think that we could continue to expect those numbers to grow as eligibility changes over time in terms of the law. I do want to take just a quick moment to formally acknowledge the hard work of clinicians across the country who are supporting patients and families through these very difficult decisions, particularly during this pandemic response period. Ultimately, physicians, nurse practitioners, MAID navigators, as they're called, or coordinators, and other dedicated healthcare professionals are critical to the delivery of compassionate and high-quality care to patients who are requesting MAID. I believe it's worth noting quickly that in terms of those who are actually assessing patients and providing MAID, this is maybe not as big a group of clinicians as people might think. In 2021, the total number of clinicians who provided at least one MAID procedure was 1,577, which initially sounds like a fairly comfortable number, but only 35% provided only one MAID procedure, while only over 16%, just over 16% provided more than 10. So, this is a challenge. It's a lot of stress on this dedicated group of clinicians. There were 10,000 MAID provisions, or over 10,000 MAID provisions in 2021, and obviously there were a lot more assessments of patients in terms of moving them through this process. So there continues to be a substantial need for service from this group of clinicians. In terms of palliative care, I'd just like to make a few comments. Obviously, I agree with the previous panelists. I had the opportunity to sit here and listen to them. The palliative care is an essential and critical service for Canadians, and particularly for those who are considering MAID. I strongly believe, and have for many years, that MAID and palliative care are not mutually exclusive. In my experience, many patients who are requesting MAID have historically or are currently receiving very high quality palliative care services that help them manage their suffering in a variety of ways. Many patients who are not receiving palliative care when requesting MAID are referred in that direction to give them the best possible care, regardless of what decision they ultimately make. And even for patients who ultimately do receive MAID, it's often the case that they continue to receive palliative care up until their final days to help alleviate their suffering, because MAID providers primarily act as consultants. They don't take over all of the responsibilities for caring for patients in most cases. I was encouraged to see in federal reporting over the last number of years that over 80% of MAID recipients had in fact received palliative care, with many of them receiving those services for 1 month or more, which I think is noteworthy. In 2021, palliative care was identified as being accessible to 88% of those who received MAID in Canada, which I think is very encouraging. And other localized studies and reports on this topic show, with some variability, that most patients requesting MAID were receiving palliative care or had access to it. I think it might also be the case that the introduction of the waiver of final consent, which was part of Bill C7, might have the effect of patients continuing to receive palliative care up until their final days, because historically some patients had been concerned about the requirement that they maintain capacity at the time that MAID is ultimately provided. So obviously, I'm encouraged by the data. I think there's still room for disagreement in terms of what would represent adequate access to palliative care for these patients. I don't feel particularly qualified to answer that question, but I believe there's probably no such thing as too much access to palliative care services, and I think that probably transcends the conversation around patients who are requesting MAID, because it appears that they actually have quite good access to those services. So I will stop there and happy to receive any questions after the next panel.
Thank you, Mr. Kekowicz. Alors, on va se reprendre avec le docteur.
So we will turn back to Dr. Roy. If you are ready, Dr. Roy, you have 5 minutes and the floor is yours. Yes, thank you, and I'm very sorry for the technical problems. Do you hear me well now? Yes, we do. Thank you. I am here to represent the position of the Collège des Médecins du Québec, for which I've been working for a year and a half as a professional inspector. The Collège des Médecins has created a working committee made up of clinicians to examine MAID. This committee, from April 2021 through now, on this issue, and filed a report in December 2021, which has been accepted by its board of directors. So these are the findings and recommendations of the committee and of the board of directors of the Collège des Médecins du Québec. The Collège would like to underscore, and this is with regard to both levels of government, federal and Quebec, that standardization of legislation is an issue. There is a lack of agreement on terms, and this leads to confusion in healthcare services. For example, in Canada, there's a use of the words handicap, illness, and so forth, not used in the same way in Quebec legislation. So this causes a lot of confusion and can lead to lack of access, for example, in the Ottawa region for people who live there. As for access to care, the working committee worked on MAID for people with neurocognitive disorders, dementia, for example, and supports advance requests made when people are still conscious but are likely to lose that capacity due to their progressive illness. And this request could be made even several years before MAID is carried out. Secondly, access to MAID for people whose sole underlying medical condition is a mental disorder. Once again, we support the provision of MAID for people with severe and persistent mental disorders who have attempted other treatments and who feel there's no other way to handle their situation. Of course, this would depend on deeper discussions of how to provide MAID for such patients, ensure that legislative safeguards are respected, and that all necessary and possible care and treatment has been provided to these people with mental disorders. And we know that in our healthcare system, that can be an issue, accessibility of healthcare being an issue. Third, minors from 14 to 7 years of age, nearly 18. The committee recommends, and the board of directors supports as well, that these minors could, with their tutors or parental parent, could make a request for MAID based on the level of persistent and intolerable suffering that they may experience and become unmanageable and senseless. The same for babies from 0 to 1 year of age who are born with severe deformations, very grave and severe syndromes, medical syndromes, whose life expectancy and level of suffering are such that it would make sense to ensure that they do not suffer, given that their possibility of surviving is basically nil. And this is something that has been used in the Netherlands as an argument, and we could explore that option. Finally, the committee addressed the issue of elders who are feeling, tired of being alive. Sometimes what we in geriatric care call, sliding into existential suffering or emptiness, who's are very fragile, whose physical abilities are so debilitated that the very fact that they're still alive becomes a real strain on them. So we feel that this is a topic that's a sensitive one, of course. People in general aren't quite sure how to approach this. We don't have a clear answer for these cases, but we would like to continue researching this with specialists and with Canadians in general, to be able to think when, for such people who are simply extremely frail and tired of being alive, might use MAID. So that is a very brief presentation of our findings and our thoughts on MAID based on 6 months of work, but also on a number of prior years of deep thinking and work on this issue. And it will be a pleasure to answer your questions. Thank you, Dr. Roy.
Chair, Senator Martin.
Thank you, and thank you for all three of you for your testimonies. That will be very helpful to our committee work. So we'll begin our first round of questions, 5 minutes with Mr. Barrett.
Thanks very much, Madam Co-Chair. Thank you to the witnesses for your time. My first question is for Dr. Pereira. Sir, since MAID was legalized, have you had any experiences where you were prevented or impeded from applying a palliative care approach for someone who could have benefited from it?
Yes, I have, and I've also had colleagues share similar experiences. I'll give you the example. For example, I was working for 2 years in a palliative care unit in my region, and in the palliative care unit, MAID is done, and patients are referred from other hospitals and other settings to the unit to receive MAID. And there were some situations where I saw patients that I thought could benefit from palliative care in that the treatment, their palliation that they had received was suboptimal, and that we could optimize it. And I was made to feel that I was obstructing access to it. So I think that does happen. And if you speak to colleagues, you will hear those examples. And that just reminds me that I think a previous speaker said that palliative care, that most patients are receiving palliative care. People who are requesting MAID are receiving palliative care. There are examples where, yes, they arrive in palliative care units and therefore on paper they are in a palliative care setting, but are not receiving palliative care. They are awaiting MAID. So I think we do need to look at those numbers a bit more cautiously and more closely.
Okay, to pick up on something that you've said there, that distinction between palliative care and medical assistance in dying is one that has been noted by the board of directors of the Canadian Society of Palliative Care Physicians, saying just that international associations of palliative care state that distinction. So can you comment then on the intrusion of MAID into palliative care in the Canadian context, please?
Yeah, and it's not only professional societies or association of palliative care, it's also the World Health Organization that doesn't see MAID as part of it. I believe that there is a distinction between the two. I also understand in a democratic society one can have access to it, but it doesn't mean that they have to be associated. What I've seen is confusion around the two. For example, a few weeks ago, had a patient who had very advanced dementia and on hemodialysis and in the final stages of her life and still receiving hemodialysis. So I met with the family and said to the family, look, we do need to consider stopping the hemodialysis. This is not being helpful anymore. And the family were very upset because they felt that I was promoting MAID. So I had to spend a long time explaining, no, we don't, this is not MAID and we don't do MAID. I also think that linking the two causes confusion because we're trying to move palliative care early in the illness trajectory. This has really been known since 2002, and there's an emerging body of evidence showing benefits of palliative care started months before the end of life. And I think associated with MAID keeps linking it to the very end of life. I have seen resources being diverted. In my region that I live in one of the peripheral areas of the region, there have been nurses and nurse practitioners assigned to do MAID assessments, and therefore not enough healthcare professionals to assess patients for their palliative care needs and address palliative care.
Okay, so to paraphrase, you would say that that end-of-life resources that are going to MAID are in some cases being done so at the expense of palliative care offerings. Is that correct?
Yeah, Mr. Chair, I would agree with that.
Okay.
In some cases, yeah.
Madam Co-Chair, how much time do I have left? Okay. Could you just briefly speak to Canada's palliative care approach as compared to international examples that you have personal experience with, please?
Certainly. So if you look at world rankings across, there's been one recent study published on world rankings. There was a large Economist study done and published in 2015 looking at where Canada stands. So we're about 10 or 12 on the list overall, but we start dropping in certain areas. So for example, in funding for resources, palliative care resources, we drop down to the low 20th spot. So there's room for improvement. In many other jurisdictions, such as United Kingdom and Australia, they put a lot of effort in ensuring that there are enough palliative care specialist services and specialist palliative care teams, and also build up what we refer to as the primary palliative care. In other words, all healthcare professionals caring for patients with cancer, heart diseases, lung diseases, renal diseases, etc., have those core skills.
Thank you.
That's not. And in Canada, we still have a long way to go to ensure that is occurring.
Thank you very much. Okay, next we will have Monsieur Arsenault for 5 minutes.
Merci,
Thank you, Madam Co-Chair. Thank you for our panelists for being here, and even to our first panelist. It's all been so interesting. Dr. Roy, let me begin with you. The statistics, or the data that we have, annual reports about MAID over the past 3 years, tell us a lot about people who use MAID versus palliative care. What we were worried about doesn't seem to be the case, though. 83% of people who ask for MAID were in palliative care, but chose to actually make a decision to use MAID, to pass, to die using MAID. We also know, based on the same data, that many of those who, 89% of the people who chose MAID without using palliative care, well, 89% of them had access to palliative care but didn't want to use it. So, based on your experience, why would someone choose MAID without necessarily wanting to use palliative care? Thank you, Senator Arsenault, for your question. MP merely. Yes, sorry, MP. I'm sorry. I will speak as a clinician. I was a doctor, a practicing doctor for a long time, practicing physician, and I myself helped set up MAID services in my medical career, during my medical career, and I've actually administered it to a number of patients. If I can speak as a clinician, working in the city of Quebec, where I was head palliative care physician at a university in a university hospital setting. Most people, as you said, you've given us the figures, had access to palliative care when they requested MAID. And this is really a continuum of care, you see, and it's something we have insisted on when MAID was brought in Quebec, that palliative care be available. In Quebec, we do have legislation that was adopted a few years ago to the effect that palliative care is not an optional in public institutions. All public healthcare institutions must offer palliative care, which is not the case elsewhere in Canada, and which is quite different from what was going on in the past. I was once told in the past, someone who was a minister told me that, oh, we're not interested in your palliative care specialization. Well, look, I have such little time, so why would a patient decide to request MAID without having used any palliative care services? Based on my experience, people who move directly to MAID services have, most of them at least, been dealing with their suffering for a long time. They have reached a point in time where palliative care is no longer relevant to them, does not seem relevant to them. For example, people with neurodegenerative illnesses, such as Lou Gehrig disease, they know that they are losing control over their body. Yes, it's not that they have no assistance. They do receive support of some type, even if it's not official palliative care, but they've reached a point where they're saying, look, given the state I'm in, I don't want intensive palliative care. I just want to move to MAID for X, Y, Z reasons. Thank you very much. So, Doctor, do you agree with what Dr. Roy has told us to the effect that palliative care and MAID are on a continuum of healthcare services? Do you see things this way? Just quickly.
That the 80% access, I think we need to stop and look more closely at that number. We don't know what the quality of the palliative care is there. Often it is very late, and often people have suffered for months and months, leading to suffering that then reaches a point where, when palliative care is finally
Je vous interromps, Dr. Pereira. Est-ce que vous...
I will interrupt you if I may, Dr. Pereira. Are you aware of and have you read the Carter decision, Supreme Court? Have you read it through?
Mr. Chair, I've read it through and I was actually part of it. So I'm very much aware of it. And I think it's
Est-ce que vous seriez d'accord avec moi, Dr.
Would you agree with me, Dr. Pereira, that the patient is really at the center of decisions? At least that's what that case showed.
Dr. Pereira?
Mr. Chair, I think it's important to say that autonomy and patient being at the center of the care has always been a foundational piece of palliative care. And I think we need to ask ourselves, are there limitations as well? And are things that we're missing, are there opportunities we're missing? Sorry.
I'm so sorry. I've run out of time. I just want to thank you. Sorry.
Very much. Next, we'll have Monsieur Thériault for 5 minutes.
Merci.
Thank you. My first question is for Dr. Roy. In your opening statements, you mentioned harmonization of legislation, C7 and the Quebec legislation on end-of-life care. I imagine that's what you were referring to. And you also spoke of the concepts of definitions as well of illness, handicap, and so on. It seems that all that is laid out quite clearly in C7. So what is the problem? Well, the problem right now in Quebec is as follows. In the Quebec legislation, the concept of handicap isn't recognized as an appropriate medical condition allowing for a request for MAID. In French, there seems to be a difference made between a physical handicap and someone with a progressing illness, such as, let's say, a simple version. You have a car accident, you're a paraplegic, you need continuous care 24 hours a day, but it's not an illness which will evolve and will be a life-limiting illness. So the Quebec legislation, as it's currently written, will say that this is a handicap and not with a progressive life-limiting illness. So the person is not eligible for MAID. If the person wants MAID, we need to, well, sorry to put it this way, but you have to sort of invent some illness that they have that is life-limiting. So I interrupt you just to ensure that we move quickly here. So it's not a Gladue-Truchon type case in which the handicap is due to a medical illness. It's not an accident or something like that. It's a life-limiting illness yes, indeed, that's exactly the case. Now, you've mentioned mental illness, mental disorders, and we worked on that recently, but I'm just going to take advantage of your presence here to ask a question about that. You've read the expert report? Yes, I have. In the report, we're told that evaluations would have to be carried out by psychiatrists who are independent, autonomous, not members of the treating team. Do you think that's realistic, given the resources available in Quebec, across the province? Excellent question. Given the resources we have and don't have, it's already difficult to access mental health services. So here's the problem. We must ensure that the evaluation is carried out by an independent professional. The therapeutic relationship with a specific patient may have lasted for years and may be in some way biased, not intentionally. So having a third independent person able to confirm the opinion of the treating physician or treating a specialist seems to be an extra safeguard to ensure that we won't be moving too quickly on a decision. Yes, but in March 2023, will we be ready to go ahead and apply the new law? Because there is a grandfather clause in there, so that's really what I'm getting at. Or a sunset clause, rather. I'm not a specialist on mental illness, but I think that if we want to get something up and running, the system will need to know how to ensure that people access MAID, but also apply the safeguards. In the report, we see the prospective, not retrospective approach. In Quebec, it's mostly retrospective as an approach. So, meaning at the end of the process, you add an extra procedure to the effect that, and it's mandatory, by the way, a committee must decide that, whether the patient and the evaluation and the whole process has respected the safeguards and met all the requirements. Do you think that that's realistic? Do you think that can be easily set up and will actually go ahead? I've given you my personal opinion. It's not necessarily the opinion of the Collège des Médecins du Québec. Setting up such procedures will be challenging. A prospective approach, I think that should be used only for difficult cases when it's not as clear, the decision is not clear, but then we'll need a definition of what that is and what needs to be clarified.
Mr. McGregor, you have 5 minutes.
Thank you, Madam Co-Chair. Dr. Pereira, I'd like to start with you. In the previous panel, we had a witness from Therasil who was talking about the research that's going on in Johns Hopkins University about psilocybin therapy used in a very controlled environment with cognitive behavioral therapy. I've also had one of my own constituents who's a palliative care physician, Dr. Valerie Masuda, who has been granted access to this through special exemptions from Health Canada, and she has reported remarkable success in helping patients who are in palliative care really overcome their anxiety. Do you have any thoughts to offer on this research? Because there have been calls not only for additional funding into the research, but also to really tackle Health Canada's overly complicated and restrictive rules. And I want you to answer this in the theme of a patient-centered approach. If we really are trying to help patients who are at end of life in palliative care meet their end in a safe and controlled way where they are not filled with that anxiety. Do you have any thoughts on this?
Mr. Chair, I'd like to thank the member for that excellent question. I think what that illustrates is that contrary to what a previous panelist said, that there are no solutions or approaches to addressing existential distress, there are, and there are growing numbers. And one of them is this class of medications, the psilocybin. And I've been monitoring the literature coming out, and the results are quite amazing for many persons who get significant relief from existential suffering as a result of that therapy, as does many people benefit from approaches such as dignity conserving care developed by Professor Chochinov. So I would argue that, yes, there are approaches to address existential distress. I've seen that in my own practice with my own teams, and it does make a difference. So I think we've got to be careful about making assertions that there are no treatments or approaches. Obviously, there's not the panacea yet, but we are stretching out there. We're improving every year on how we can address these needs. Thank you.
To the Champlain Regional MAID Network, so am I correct? The areas of service, you include the City of Ottawa, but also Renfrew County, Stormont, Dundas and Glengarry, Prescott and Russell, North Lanark, that's correct? In the context of, we've heard comments about the challenges that exist for rural Canadians in accessing service. Can you add anything to what you've heard, like based on your own personal experience, comparing patients who live in the City of Ottawa compared to Canadians who live in those more rural areas that your network also serves?
Yeah, certainly there are some differences in terms of the experience just living in smaller communities and the type of institutions that exist in those communities. I mean, thankfully, one of the things that, not that there were many things that were positive about the pandemic, but virtual care became a very normal modality of providing linkages between patients and providers. So I think we were able to mitigate more effectively some of those disparities to the extent that they exist by pairing people with services that they need. I wouldn't say that it's perfect by any stretch of the imagination, and I also don't know that I would say that even all rural communities are the same in terms of their access. So I think we're making some progress, but I appreciate the question.
Thank you. And as Dr. Pereira, I'd like to return to you for my last minute. You've talked about how we're not having enough physicians getting that palliative care training. In your observations, how are our medical schools meeting this challenge, especially when you look fast forward 10, 20 years, the demographics of Canadian society? How are the colleges of physicians and surgeons meeting this? And do you have any thoughts about specific regions of Canada that may have a higher than average elderly population? I've spoken to members of the provincial legislature in Nova Scotia. They have a very high elderly population, and they don't think the current funding model adequately looks after their particular needs as a province.
So very briefly, Dr. Pereira, thank you.
Correct. So the medical school, the authorities that oversee the medical schools and residency programs have incorporated palliative care as a core competency, but we still struggle as educators to get palliative care content inside the curriculum and to get rotations done. There are a number of barriers, and one of them, insufficient faculty. Absolutely, there is a lack of palliative care specialists. I know the Champlain region very well. I worked there for a few years, and there's examples, for example, in Petawawa, where the family health team trained up the whole team to provide a palliative care approach, and it's made a very big difference. But there are still many areas across the country, and you've highlighted some of those rural areas where there aren't enough resources. I've also helped in New Brunswick trying to build up palliative care capacity there.
Thank you, Dr. Pereira. Now over to you, Mr. Co-Chair.
Thank you, Senator Martin. We'll go proceeding with the Senate questions, beginning with Senator Mégy. Sénatrice, vous avez 3 minutes.
Merci, Monsieur le Président.
Thank you, Mr. Chair. I'm very lucky to speak after my colleague, McGregor, given that his question was one of mine, so I'll pick up where he left off. We see, and more so, that people receive a good deal of information about MAID, Canadians in general, or all professionals. So it's a program being set up and noticed by all. But what I have seen is that Canadians don't really know what palliative care is about, and when they're offered palliative care, everyone seems to back off. It's like, whoa, not so sure. Now that palliative care is being compared to some extent to MAID, and they seem to be alternative choices for some, what can we do to ensure that people understand palliative care, know that it's available, and know what it is as compared to MAID? And what can we do to ensure that's the case for professionals as well, via, let's say, the Collège des Médecins and so on and so forth, the training system that we have for our doctors and so on? And what will we set up to ensure that people at end-of-life care are well counseled so that they make a choice? Has this been discussed at the Collège des Médecins du Québec? Yes, there a good deal of thought has gone into this. Information about palliative care and about access to palliative care is something that's been a problem for a long time. People are afraid of discussing death, of facing their deaths. These are difficult topics. The quick path to MAID has been privileged because it's something that's easier to transmit to the public. It's not that it's easier to talk about, it's just that it's something that the media picked up on. It was something new, something that everyone wanted to talk about. But palliative care, how do you bring it up? Who do you bring it up with? What words do you use? So the media need to address this. You need to ensure that there's press coverage, and to my mind, from what I've seen, the best ambassadors for palliative care, the best able to talk about it, are the families of those who have received palliative care. Yes, our mother, our aunt received palliative care, and it was a very positive experience for all of us. They were comforted, their suffering was relieved, and so on. For doctors, well, Dr. Pereira brought this up. Yes, medical faculties need to be involved, and the curriculum needs to include palliative care, although, unfortunately, doctors have such a heavy curriculum as it is. Difficult to say, oh, you know, you just have to study an extra year to be able to cover everything, so we need to condense stuff even more. That said, all doctors need to deal with the fact that all their patients will eventually die, as we all will, and they need to be in contact with palliative care, have some experience of it during their training. Thank you, Senator. Senator Kutcher.
And thank you to the witnesses. Before I ask my questions, I'm asking the chair if he could request that Dr. Pereira provide this committee with a written report supporting his opinion that, one, people are being provided MAID instead of access to palliative care when they want palliative care, and two, the data that show people are receiving MAID have received suboptimal palliative care, and three, that resources are being diverted from palliative care to MAID provision outside the usual ongoing annual reallocation of resources in the healthcare system. So my questions are for Dr. Karawicz. Did I get it correct? Karakowicz, sorry about that, and then for Dr. Waugh. So I'll just ask both questions and ask you to respond. Dr. Karakowicz, you raised a concern about the necessity or the possibility of a real shortfall in the healthcare workforce that can provide MAID and palliative care, and both are very important. Mm-hmm. So the question to you will be, how can that human resource problem be addressed by the federal government? Mm-hmm. And just to think about, would targeted healthcare transfer funds might be part of that solution? And then for Dr. Waugh, would regulatory bodies have within their jurisdiction being able to require that MAID providers have completed a national training program in MAID assessment and delivery?
So that's an excellent question. I think it's something we've struggled with, quite frankly, in terms of what the strategies look like. I think one of the interesting things about MAID is that most clinicians that are providing MAID are not doing it full time. They are doing it in addition to other work that they're committed to. And so it has to be rewarding for them. It has to be meaningful for them. I think certainly the volumes are one thing in terms of them increasing over time. The complexity may also increase over time as new patient populations start requesting. I think that there have been some innovative attempts to develop like MAID coordination services that really support clinicians, because it can be very sort of administratively burdensome in cases to have a large caseload of patients, for example. So I think, focusing on those types of strategies where there's a team that's supporting, not just the clinician on their own supporting the patient, but a team, nurses, social workers, other specialists perhaps who could be available to support. I think those are helpful.
Thank you for that. Dr. Waugh?
Thank you for your question. If you don't mind, I will continue in French, make sure I make my more clearly. Au niveau de la formation en soins palliatifs.
Palliative care, then. We've made a good deal of progress since the beginning of this approach. There was no training at the outset, and people sort of got organized on their own. And now in Canada, there is a working group which is working up a curriculum, a training curriculum for MAID to be provided to physicians and nurse practitioners. And I'm helping look that over. And this should become available in the spring of 2023. So when it comes to training doctors and nurses in MAID, I think that the building blocks are turning up. We'll be able to use them soon. It should have been done in the past. There's still work to be done, of course. For example, and it's an interesting piece of the puzzle, in my practice, very few physicians refuse to accept MAID. Some say, I don't feel I could administer it, but I understand my patient's need, and I'm able to refer this patient to someone who has trained appropriately and is able physically, psychologically, and morally is capable and able to provide the service. Thank you. Thank you, Dr. Waugh. The floor is now Senator D'Alphonse. Thank you. My question is for Dr. Kekowicz. You have carried out a good deal of research using data now available. Is there any data showing that people have chosen MAID because they have received poor quality palliative care? You said that 80% of people who receive MAID were already in a palliative care setting.
Concern, I think I would agree to some extent with Dr. Pereira that there are limitations in terms of the data, and I believe that Health Canada is going to be collecting more data, more specific data on palliative care involvement to help inform these types of discussions. I mean, I'm not aware of any reports that kind of support that claim, but the reality also is that it's not the case that 100% of patients, receive palliative care, right? So I think it goes back to understanding what does adequate access to palliative care look like.
J'aurais une deuxième question dans mon temps limité.
I have a second question, though we've got little time. You are also a specialist in ethics. So I have a question that's about ethics. I understand that all MAID issues, even, sedation is an ethical issue. And this is a considerable, big consideration, the ethics, I mean, when MAID is administered for mental disorders solely. So are the concerns real? What can we do about them?
Medical condition. Yeah, I think we've had a lot of conversation about that in preparation. Certainly, I'd be lying if I said there wasn't apprehension about how we're going to be able to effectively support some of these patients. I think it goes back to another comment, perhaps, which is that we're talking a lot about palliative care. There are other services that patients also require timely, ongoing access to that we're seeing in terms of mental health supports, complex pain, other specialized care. And so I think that we need to make sure that recognizing, not all of these patients are going to receive MAID, certainly, I wouldn't say. So what then is the support also for these patients to make sure that their care is good?
Thank you.
Merci, Sénateur. We'll now go to Senator Martin for 3 minutes.
My first question is for Dr. Pereira. What is meant by specialist palliative care versus the palliative approach to care as outlined in the framework for palliative care in Canada? And why is that so important with respect to providing access to palliative care? And where does Canada stand on that?
Very good. So if you look at jurisdictions that have done very well in accessing palliative care, they've developed both specialist palliative care services, and they've also ensured that all healthcare professionals are getting basic training so that they can identify patients earlier that would benefit from palliative care. They can start addressing the psychosocial, spiritual, physical distress that those patients are experiencing. And by doing that, patients then have got a lot more access to palliative care. There was an earlier assertion that there's been considerable funding going into palliative care across the country. That may be true in some jurisdictions, but not in all. In my region, for example, we don't have enough specialist funding for specialist palliative care physicians. I know another hospital that's been trying in Ontario, that's been trying for years to get extra funding to build palliative care specialists. And we also struggle with funding to make sure that we train up healthcare professionals in practice, the very professionals who are going to be asked by patients, what choices do I have? What are my options? When they don't know what palliative care is, when they keep equating it to the only very end of life, when the patients and the public still think of palliative care only at the very end of life, we have a problem. And I think we do need to address that.
And speaking of training, I see how important it will be to have training and really all people in the system if we're expanding MAID, because we'll need these professionals. So to what extent has palliative care education been integrated into medical, nursing, and social work training programs in Canada?
Look, Mr. Chair, I think we've come a long way in the last 2 decades. I've been doing palliative care since 1995, and over the years, I've worked really hard to try and get palliative care integrated into curricula. But it's a real challenge, and Dr. Roy alluded to some of that challenge as well. But there are ways of doing it. I think it's unacceptable that that specialists specializing in internal medicine and cardiology and nephrology and respirology don't get core palliative care training. How can they inform their patients with the options appropriately when they don't have that training? I think it's still not adequate that only 30% of medical students across the country have clinical rotations. And we're not even speaking about nursing schools. because in nursing schools, there's still major gaps in the curricula. We need resources, we need funding. I've experienced many pushbacks, largely around we don't have the resources, we don't have the space, we don't have the time. But we do actually, and we can be innovative. And there are examples across the country how that can happen. Thank you.
Thank you, Senator Martin. This brings our panel to an end. Just before I finish, this is for you, Dr. Pereira. You probably heard the request from Senator Kutcher to provide, if you can provide documentation that supports some of the points that you raised during your opening remarks and in answering questions. Are you in a position to do that?
Yes, sir, I am. It will take a few days because I've got some family priorities I've got to deal with.
That's fine, but thank you for providing that additional information. With that, thank you, Dr. Pereira. Merci, Dr. Roy. Thank you, Mr. Kakowicz, for appearing in front of the committee this morning. We very much appreciate it in our continuing analysis of the theme of palliative care in the context of medical assistance in dying. Thank you very much for your appearances this morning. And with that, for the committee, our next meeting is Tuesday the 18th. We won't be here next week, of course, and we'll continue with the study of palliative care. With that, thank you very much, and this meeting is adjourned.